Okay, so today we'll talk about rheumatoid arthritis. Now we'll start with a case study. We have a 42-year-old lady presented with 9 months history of pain in her hands, both hands. The pain was more severe in the morning and was associated with early morning stiffness of long duration. On examination, there was swelling and tenderness of the joints of both hands. We sent for ESR, C-reactive protein, rheumatoid factor, and anti-CCP, and they all returned positive. What is the differential diagnosis and how is rheumatoid arthritis diagnosed and treated? These are the main objectives of this video. Okay, so let's first define rheumatoid arthritis. Rheumatoid arthritis is a chronic autoimmune inflammatory systemic disease with polyarthritis. So every single word in this definition has a meaning. First of all, it's a chronic disease, and the duration in the history of rheumatoid arthritis is very important. No diagnosis of rheumatoid arthritis if the duration is less than 6 weeks. It's an autoimmune disease. There will be some antibodies like the rheumatoid factor and anti-CCP directed against the cells of the human being. It's an inflammatory disease, and this is very important. We will need to differentiate inflammatory pain from mechanical pain. And inflammatory pain usually goes with rheumatoid arthritis, while mechanical pain goes with osteoarthritis, and we will try to differentiate between these two types later. It's a systemic disease. No system is actually immune from rheumatoid arthritis, and the arthritis is polyarthritis. Usually it's polyarthritis, and that is more than four joints are usually involved. Okay, so rheumatoid arthritis is more common in females. It is a middle-aged female disease, and this has suggested some role for sex hormones in the pathogenesis of rheumatoid arthritis. And also there's a fact that rheumatoid arthritis actually goes into remission during pregnancy. The symptoms are less severe during pregnancy, and this suggests some role of sex hormones. Okay, now briefly we will talk about the pathogenesis of rheumatoid arthritis. Rheumatoid arthritis mainly target the synovium. If we are asked what is the most commonly affected organ, or what is the main target of the rheumatoid arthritis process, then the answer will be synovitis. Synovitis is the hallmark of rheumatoid arthritis. This synovitis usually heal by formation of granulation tissue. This granulation tissue is often called pannus. This pannus is composed of many types of cells. Of particular importance for the pathogenesis of rheumatoid arthritis is the myofibroblast. These cells are differentiated fibroblasts in which they have the ability to contract. Contraction of these cells is responsible for the main deformities found in the joint. So when this pannus on these myofibroblasts contracts, they will make the bones close to each other, and they may hit each other, resulting in erosions. Also, they may contract and push the bones away from each other, resulting in deviation. And also there will be decreased joint space because the bones will become much closer to each other. And this triad may be the hallmark of what's called erosive arthritis, and we will talk about this later. So the process starts by synovitis. This synovitis, the inflammatory process is started by the activation of T cells, and the T cells will produce many factors of which the most important is tumor necrosis factor alpha. The main factor to blame in rheumatoid arthritis is the tumor necrosis factor alpha, and this is a very important point because we will return to it later when we will talk about the treatment of rheumatoid arthritis. So the process starts with synovitis. This synovitis heals by pannus formation, which result in the accumulation of myofibroblasts. When these myofibroblasts contract, they will cause erosions. When the bones hit each other, they will decrease the joint space and they will cause physical deformities by deviation of the bones. Okay, now let's talk about the clinical features. Actually, the clinical features, we have talked about it in the case, but let's repeat it. This process of rheumatoid arthritis is basically symmetrical. Rheumatoid arthritis actually is the most common cause of symmetrical inflammatory arthritis. So the process is symmetrical and the pain is inflammatory, as we said earlier. And what is inflammatory pain? Inflammatory pain is that pain that is more severe in the morning and that decreases towards the end of the day. This actually makes sense. When the joint is at rest, for example during sleep, the inflammatory process can take place. So when the patient wakes up, he will feel pain and the inflammatory process sign will become apparent. When the patient moves throughout the day, the inflammatory mediators may leave the joint with movement and the pain reduces. Also, there is early morning stiffness of long duration. This is also a characteristic of inflammatory type of pain. The other type of pain is the mechanical pain, which is seen in osteoarthritis. Mechanical pain actually is more severe towards the end of the day. When the patient moves, the pain, it's a mechanical process, so the pain gradually increases, and also there is swelling. This is the early presentation of rheumatoid arthritis: symmetrical inflammatory pain with early morning stiffness of long duration and swelling of the joint. Okay, later there will be physical deformities, and this is the action, maybe the action of the myofibroblasts. The main physical deformities in the hands are those. We will have some characteristic deformities, as this one neck deformity and the botonia deformity. These deformities are rather characteristic for rheumatoid arthritis. Also, we will have the Z-thumb deformity. There will be ulnar deviation of the fingers. As we said, deviation is a sign of rheumatoid arthritis, and there may be also ulnar subluxation. Okay, this is another photo about the picture about the deformities. This is this one neck and the botonia deformity are clear here. Okay, this is the foot deformities in rheumatoid arthritis: hallux valgus, hammer toe, and rheumatoid nodule. Okay, still more severe, the disease will start to strike other systems in the body. We said earlier that there is no system that is immune from rheumatoid arthritis, but here are just the most frequently asked manifestations or features in the exams. In the skin, we will see rheumatoid nodules. Rheumatoid nodules is a specific characteristic feature of rheumatoid arthritis, and it is also characteristic for seropositive disease. We will talk about this later. In the eye, we will see the keratoconjunctivitis sicca. This is the most common extra-articular manifestation. Also, there may be episcleritis and scleritis. In the lung, there is Kaplan syndrome. Kaplan syndrome is actually rheumatoid arthritis plus pneumoconiosis. This is Kaplan syndrome. In the nervous system, there may be peripheral neuropathy, mononeuritis multiplex, which is an inflammation of the vessels of the nerves, and also there is atlantoaxial subluxation. This is a musculoskeletal feature, but it will affect the spinal cord. Atlantoaxial subluxation can cause compression of the spinal cord when there is hyperextension of the neck. This point is very important because it carries a clinical significance. These patients who have atlantoaxial subluxation, if they are going to have any surgery, you should inform the anesthesiologist about their condition, because if he do hyperextension, this will compress the spinal cord and may result in quadriplegia or even death. In the hematology, there will be anemia. Anemia could be of a chronic disease, could be of the use of NSAIDs, and there will be Felty syndrome. Felty syndrome is rare, but it is composed of rheumatoid arthritis, splenomegaly, and neutropenia. In the heart, there is ischemic heart disease. Ischemic heart disease is the most common cause of death in rheumatoid arthritis patients, and in the renal system there may be amyloidosis, which will present as renal failure. Okay. These are the rheumatoid nodules. Rheumatoid nodules actually are seen on the extensor surface of the forearm and fingers. This is the specific site for rheumatoid nodules. Okay. What is the differential diagnosis of polyarthritis? A patient with this presentation may have rheumatoid arthritis, viral arthritis. Viral arthritis, very similar presentation to rheumatoid arthritis, but the duration is less than 6 weeks. That's why I said earlier that there is no diagnosis of rheumatoid arthritis if the duration is less than 6 weeks. Also, we may have osteoarthritis, and the difference is clear, is that osteoarthritis actually is a mechanical type of pain. Also, osteoarthritis affects the distal interphalangeal joint, whereas rheumatoid arthritis favors the proximal and middle interphalangeal joints in the hands. Also, we will have systemic lupus erythematosus, and in this condition, the age is younger. This usually presents in the second or third decade of life. And also, the systemic lupus erythematosus is usually a non-erosive disease, whereas rheumatoid arthritis will cause erosions and deformity. Okay, so what's the diagnostic criteria for rheumatoid arthritis? It depends on 4 major factors. The joints involved, and there are many divisions for this criterion. But according to the number and size of joints involved, the patient can get 5 points from this entity. ESR or C-reactive protein, 1 point for each. Duration of more than 6 weeks, 1 point. And rheumatoid factor or NTCCP, 1 point. So when we collect these, if the patient has 6 points from this criteria, then you can diagnose rheumatoid arthritis. Okay, what about the investigations? The main lab investigations are these: ESR, C-reactive protein, rheumatoid factor, and NTCCP. Of course, you will send for X-ray of the hands mainly. Okay, so ESR and C-reactive proteins are acute phase reactants. They are essentially the same, but C-reactive protein is faster to appear and faster to disappear, so it is more useful for the follow-up of the patient. Rheumatoid factor is an IgM against the immunoglobulins of the human body. Rheumatoid factor is non-specific for rheumatoid arthritis. It is very non-specific. It is seen in normal people. It increases with age. Also seen in SLE, in tuberculosis, in hepatitis C virus. Whereas NTCCP is actually the most specific diagnostic test for rheumatoid arthritis. NTCCP is very specific. If it is positive, 99% this patient is having rheumatoid arthritis. Okay, what about the X-ray findings? These are the main X-ray findings in rheumatoid arthritis joints. Swelling may be the only sign early. Swelling of the joints can be the only sign in early presentation. Osteoporosis Osteoporosis results from both the disease activity and from the chronic use of steroids. And then there will be the signs of erosive disease, which are the joint space narrowing, the erosions, and the displacement or deviations, and ankylosis. And ankylosis usually results whenever the bones get closer to each other. There will be stimulation of bone formation. Okay, this is a picture of the rheumatoid hand. Rheumatoid hand, we can see here bone erosions. We can see displacement. Osteoporosis of the phalanges is seen here. This is an erosive disease. Okay, what about the management of the patient with rheumatoid arthritis? The gold standard, first of all, rheumatoid arthritis is an irreversible process. Our aim is to halt the progression of the disease. We cannot reverse the process. The gold standard drug for rheumatoid arthritis is methotrexate. Methotrexate is a folic acid inhibitor or antagonist. Methotrexate mechanism of action is unknown in rheumatoid arthritis. This drug is very effective. Its main side effects are liver and lung toxicity, also nausea. These all can be reduced if we give folic acid along with methotrexate. Okay, methotrexate takes about 2 to 3 weeks to start working. So during this period we can use bridge therapy, which is composed of corticosteroid mainly. Okay, if methotrexate is contraindicated or intolerable or failed, we can switch or add another drug, which is leflunomide. Leflunomide is the alternative for methotrexate. It is also very effective in rheumatoid and halting the progression of the disease. Both these drugs, methotrexate and leflunomide, are teratogenic and contraindicated in pregnancy. Now, what if both methotrexate and leflunomide failed? The next step is to use anti-tumor necrosis factor alpha. That is why I said earlier, tumor necrosis factor is the main player in the pathogenesis of rheumatoid arthritis. These agents, there are 3 main agents in Iraq: infliximab, adalimumab, and etanercept. The first 2, infliximab and adalimumab, target the molecule, the tumor necrosis factor. They will bind to it and block it, whereas the etanercept will block the receptor of the tumor necrosis factor alpha. It is very important before we prescribe these drugs to do a tuberculin test to ensure that this patient is free of tuberculosis, because these drugs will decrease the immunity, and if this patient has latent TB, this will result in reactivation of the tuberculosis. We can also check for hepatitis C virus